Good evening and welcome to Giovanni's Autism Training Center. Tonight we are focusing on understanding diagnosis. My name is Kristin Kiggins. I'm a licensed mental health counselor and I am the supervisor of behavioral specialists here at Giovanni. I work with individuals who reside in our group homes and as well as our day programs. So we have a couple of objectives that we're going to touch upon tonight. We're going to understand what intellectual disabilities are and what they mean. But more specifically, we're going to go into autism and its symptomology, what symptoms and characteristics we commonly see with autism. To understand autism and how it develops as it's a developmental disability, we're going to look at some of the milestones and the key things to look for in child development to see if maybe your child has been exhibiting some of the symptoms in their early stages that might lead to a potential autism diagnosis. We're going to look at different presentations and different gender identities and different cohorts, some of the comorbidities that happen with autism, so the other diagnoses that are often commonly occurring, as well as some sensitivity training. How can we work with these individuals with autism to the best of our ability? And the bread and butter of what I like to do, the functions of behaviors. How do we understand the behaviors and help to make some changes to either reduce or eliminate those behaviors? So when we're talking about a disability, the American Disability Act defines a disability as a physical or mental impairment that substantially limits one or more of the person's major life activities. Things such as breathing, walking, speaking, learning, lifting, or caring for themselves. A developmental disability is a group of conditions that occurs that causes impairments in physical, learning, language, and behavioral areas. These conditions begin during the developmental period of one's life. The onset of age to be diagnosed with a developmental disability means it has to happen before age 21 years of age. So one of the other developmental disabilities that we know and most commonly know as an intellectual disability, this is when an individual has an IQ score of 70 or below. The average IQ of the general population is about 100. So we can see individuals with mild intellectual disabilities all the way to severe, where their IQ is much lower than 100. When an individual has an intellectual disability, they have deficits in their conceptual skills, how they understand money and time, literacy, and number concepts. Different social skills, how they interact with others or their interpersonal skills, social responsibility, things like self-esteem, whether they're naive or gullible, social problem solving, and the ability to follow rules and laws to avoid becoming victimized. And lastly, practical skills, that day-to-day activities that they engage in, whether it's making sure they're safe, traveling independently, occupational skills, acts of daily living, how they take care of themselves, and how to use concepts like how to use the telephone, how to use money. So we see these deficits in hitting these three areas to one degree or another. So intellectual disabilities often occur with another disability or their comorbidity. So you'll see individuals with an intellectual disability have things like attention deficit hyperactivity disorder, depressive or bipolar disorders, those mood disorders we see, anxiety disorders, difficulties with impulse control, major neurocognitive disorders, things with memory and impairments in language and speech, cerebral palsy, seizure disorders, and autism spectrum disorder, which is what we're really focusing on tonight. And I wanted to highlight that autism spectrum disorder can happen with intellectual disability because an individual with autism does not necessarily have to have an intellectual disability. There are many people who have autism who have very high IQs, so they don't meet the criteria for an intellectual disability. So sometimes it happens together and sometimes it happens separately. So what is autism? Yeah, question?
Yes. Back to autism, ASD.
Yes.
Is there a thing as a mild case or borderline?
Yes, so autism spectrum disorder is exactly what it says as far as spectrum. And we'll go into the different levels a little bit later, but if some of you may know, Asperger's used to be a disorder, which would be the most mild case of autism. They removed that from the DSM, or the Diagnostic Statistical Manual, and incorporated it into autism to really show it can be very mild or more severe in range, depending on the symptoms they're exhibiting. So yes, absolutely. And when you think of people who have autism and don't have that intellectual disability, they are very high functioning, right? Because they have a higher IQ, maybe a more understanding than someone who has autism and an intellectual disability.
So in other words, you have to have it before age 21?
Yes, both of them are intellectual disabilities, and autism are either diagnosed before age 21, or there has to be some sort of symptoms and proof that they were experiencing it before age 21.
So what's the most age that is recognized?
So autism is typically diagnosed between 3 and 6 years of age, but we can actually screen a lot earlier than that. And I'm going to go to the milestones a little bit later, but absolutely, you can be diagnosed later in life, especially if it is more mild, but we typically see some of those characteristics very early in life. Okay. If anyone has any questions in the chat too, please feel free to chime in and I'll address them as soon as they come up. So when we're talking about autism, we're talking about persistent problems in social interaction and communication across a wide variety of activities. All right, there may be a reduced ability to share emotions with another person. They have very specific interests that they enjoy. Poor ability to communicate and to understand verbal and nonverbal gestures and cues. So when we're talking about the communication ability, some individuals with autism may be verbal, some may be nonverbal. So their communication is affected. Also their socialization, how they interact with others around them, and understanding some of the societal social cues that we understand. They may not register or process them as easily as we can. So a great example, if I'm standing with my arms crossed like this, most people would understand that I'm either offended or upset or angry. That might not be perceived as easily for somebody with autism. We also see repetitive behaviors and patterns, engaging in either pacing or STEM behaviors, hand flapping, rocking back and forth. These are behaviors that they engage in to self-soothe, vocalizations, hummings, things like that, but they do them very frequently. Fixation and restricted interests. Individuals with autism have highly specified interests that they like to talk about, and not everybody might like to talk about them, but that's what they know, and they know everything about it, and they have a hard time communicating or socializing with others because they may only want to talk about trains and have difficulty making friends about caring about what they like. Okay. The last but not least, sensory. Sensory issues are very pronounced in autism spectrum disorder, where they either have heightened sensitivity or a lack thereof. So the lights in the room may be so bright that it's affecting their eyes, or loud noises may be really irritating for them. So you'll see that they're very sensitive to all of their sensory needs: auditory, visual, tactile, taste, touch, things like that are very highly sensitive. Or on the flip side, they have a lack of sensitivity, so they make it up by making noises or hand clapping, things like that, to stimulate themselves. So it's either overstimulation or understimulation. But what we know about autism is that the growth rates have grown exponentially over the years. In 2004, it was 125 individuals were diagnosed. 2018, it was 1 in 58. And as soon as 2020, it's been 1 in 54. So we're seeing an increased trend in how many people are diagnosed with autism. And like we said, there's mild cases. So it's not all severe. It's a mixture of all these different abilities being diagnosed too. What we do know is that boys are 4.5 times more likely to be diagnosed than females. And I'm going to talk about why a little bit later. So when we're talking about those early signs of autism, the American Academy of Pediatrics recommends actually their children to be screened between 18 and 24 months old. They feel that this way they've reached enough milestones that they'll be able to see maybe some red flags that would indicate autism might be present. The average age of individuals diagnosed is between 3 and 6. So if we know we can see it as early as 18 months, we're missing a huge window of when we can actually start interventions and treatment if we start looking at things a little bit earlier and being more proactive about it. We do know that effective treatment, the sooner we put treatment in place, the more successful that they will be. Okay, so on this next slide, I have just a list of general milestones that typical children tend to meet at these age ranges. So at 3 months of age, we typically see kids watch faces, respond to sounds. You know, if they hear a clap over there, they're turning their attention to that. Somebody with autism who may not be diagnosed yet won't react to sounds over there or make eye contact and watch faces. So we see these little red flags go up of what's going on here. And a lot of the times it may come off as a hearing issue, but it's really more of the disconnect and the socialization piece that they're struggling with. We move on to around 7 months, social play, engaging with others, being able to babble, make sounds. You know, individuals with autism, like we said, have difficulty with socialization. So they're not engaging with kids their age or even their parents. They're not beginning to babble. So there might be some verbal communication issues that we're starting to see a little bit more pronounced. And I think it's really important to address that there's a difference between kids who are shy and kids who are not playing with others or engaging with the people around them. It goes in all settings. So if the child doesn't want to play with others because they're strangers and they don't know them, are they playing with you, their siblings? If not, then that's something we want to put a closer eye to. So I'm going to move on from this slide, but there's another great website called Navigating Autism, which really goes into these milestones and helpful for parents to understand where their kids should be performing or where their child should be at based on where they're developing. So we talked about some of the autism symptoms that we see, but some of the common characteristics that nonverbal communication, maybe they sign, they use gestures to communicate if they can't do it verbally. Echolalia. Echolalia is interesting because it is verbal communication, but it's just repeating back what's being asked. So if I said to someone with autism, "Did you have a great day?" They may say "great day," but it's not really a response. It's just mimicking what I said without the real connection to what's maybe being said. We talked about poor eye contact, humming and visual vocalizations, time and detail oriented. Individuals with autism love a schedule and a routine, and any disruption to that makes them very upset. So you'll notice that even slight changes in the schedule, they may need to be given awareness beforehand or have a really hard time calming down and de-escalating from that situation. Let me see what else. Oh, refusal behaviors. We probably see this the most often, especially when it comes to things like technology, iPads, cell phones, not wanting to stop an activity they're enjoying and transitioning to something else because they're so focused on what they're doing. So we see a lot of difficulties when it comes to getting to school, coming home from school, getting ready for bed. If they're doing something that they really enjoy, they're more likely to refuse something that's not as fun as what they want to do. And socially inappropriate behaviors, we've noticed disrobing, public masturbation, and a lot of that goes back into the socialization and what's culturally and society accepted. So if you have an individual who is engaging in masturbation in public, they may not be aware that that's not something that people typically do. Or if their parents said, "do that in the bathroom," they may not realize that they mean the bathroom at home and not doing it in the bathroom at program or the mall. So it's very specific and not really understanding that nonverbal language that we're reading between the lines that we kind of do. So just to kind of go back over those two big areas, the social and the sensory, they have difficulty making friendships and maintaining friendships, all right? They miss those social cues, have a hard time developing their relationships, and just knowing what to say in a back and forth conversation. But what's really important to understand with individuals with autism is not that they don't want friends or they don't want to communicate with others. It's that they simply don't know how. They want the connection, they want that relationship, but they just don't know how to make it happen. and putting into account their sensory overload. How much is that getting in the way of their daily activities and preventing them from being successful? So we talked a little bit before about the wide range of autism. So there's actually 3 levels of autism. Level 1 being individuals who require support. These are individuals who would be more in the Asperger's kind of category. They're able to function, they're able to do their ADLs and have a higher level of independence, but maybe they have trouble engaging in conversations or maintaining those friendships. Difficulty with organization and being on top of things like doctor's appointments or paperwork, and may struggle a little bit with the difficulty to transition, but they're communicating. They may get frustrated, but they're able to make their way in society with minimal support. If anyone's seen the shows on Netflix, I'm a huge Netflix fan, but there's 2 shows, Atypical and Love on the Spectrum. These are individuals that would fit into this require support category, where they're very independent, but they need a team. They need a little bit more help just to get them going throughout the day. Level 2 is require substantial support. They have a little bit more limited social interaction, more specified interests that make it difficult to communicate, those restrictive and repetitive behaviors, and may have nonverbal communication. So maybe they use an iPad to communicate or sign language, things like that. So they have a little bit more need of support from others. And level 3 requires very substantial support. These are individuals who have autism, have severe deficits. They're not able to take care of themselves without reminders or physical assistance. They may engage in possible self-injurious behavior, being frustrated and not knowing how to cope with some of the feelings and situations that they may encounter. Okay. Yes.
Just a suggestion. Would you be able to just say the name of the slide, the new one that comes up, or the number, if there's a number of the slide, just to help everyone?
I don't know. Hold on, let me see. Okay. Do you know what, does anyone know what slide we're on right now?
I don't have to count pages. Autism as a spectrum.
Yeah.
It says autism
Okay.
as a spectrum.
So I'm just going to say next slide to see if that helps to follow along, or the title of the next slide. Maybe that'll help a little bit
If
more.
they
but I
have
don't
a
have the numbers.
title, it's
That's
really
fine.
hard to follow
Okay,
otherwise.
so moving to the slide with the graphs on it. Okay. This slide, it just goes to show you that those 3 major areas, the socialization, the communication, and the repetitive behaviors, they interchange very different from person to person. So someone might have really great communication skills, but maybe they have less socialization skills. They have more difficulty in that area, and it fluctuates. Dr. Joe Zweig, who is also in the Autism Training Center, I'm going to quote him. He says, once you meet somebody who has autism, you met one person with autism. Everyone looks different and everyone presents differently. So it's a combination of how they fit into this kind of sliding scale in these behaviors. All right, so on the slide for male versus female presentations, I said earlier that males are 4.5 times more likely to be diagnosed than females, and wonder why that is. So what we've noticed is that males tend to have more restricted repetitive behaviors, that rocking back and forth, hand flapping and stemming, where females have more restricted interests that are a little bit more appropriate or easily overlooked. So females who have autism may be more interested in things like books and celebrities and fashion, animals, where other girls their age or other females their age may have similar interests. So it doesn't stand out as much as some of the male repetitive behaviors that we see. Also, females who don't have an intellectual disability are really good at imitating others and engaging in play successfully. There's this innate drive that these women have to camouflage their behaviors more successfully than males do. And when we think about the diagnostic tools that we use for autism, it's geared more to men. So we don't hit as many of the female categories, or they may be overlooked or misdiagnosed because we haven't developed a diagnostic tool yet that may include some of the more female-like symptoms that we see. All right. And it's also important to note, I actually learned this the other day when it comes to individuals with autism. We know that autism does not discriminate towards age, towards ethnic background, nationality. Everybody has the same possibility of being diagnosed with autism. It does not affect one population more than the other. But we have noticed a trend where individuals who are diagnosed with autism tend to have a sexual orientation in the LGBTQ plus category. And there's not a lot of detail to say why that is necessarily, but again, people are speculating that it has to do with that not conforming to societal norms and being more expressive. I like that person and I like that person just because, and not necessarily fitting into a role or a category specifically. So I just thought that was interesting and something to point out. So can someone be diagnosed with an intellectual developmental disability like autism and a mental disorder? Absolutely, yes. People with intellectual developmental disabilities like autism are actually at a significantly higher risk of developing a mental illness. We actually see that it's estimated as 33% higher, and some other resources saying that it's actually a lot higher than that. And when you think of the deficits of individuals with developmental disabilities, that conceptual, social, practical skills, it makes sense. They're struggling with day-to-day tasks and activities that may make them anxious or depressed or, in some sort of distress at some point. We also know that there's a lot of professionals who are not yet very comfortable with diagnosing someone who has an intellectual disability with a mental disorder. It's sometimes overshadowed by that developmental disorder and thinking it's just a part of it instead of an additional diagnosis. So when we talk about mental health diagnoses and disorders, we're looking at things that are clinically significant, something that's really causing them distress and a disturbance in their cognition, their emotion regulation, and behavior. So one of the most common things I hear is people will say, I have OCD, I have obsessive compulsive disorder, I like things neat. Well, if it's not causing you distress or a disturbance in your daily living, it's not OCD, you just like things neat and clean. But if it's something that's really impacting your day-to-day functions, then it might be something that is more disordered. Yes.
Could they both be diagnosed at the same time, or does it have to be separate testing?
So can they be diagnosed at the same time or separate testing? Well, there's different tools to diagnose each different diagnosis. So they could potentially be diagnosed at the same time with multiple things, but using separate tools to do that. So like the Beck depression scale versus a tool for autism and things like that. So what are some of the mental health diagnoses that's often commonly associated with autism? Anxiety, depression, bipolar, ADHD, sleep disorders like insomnia, epilepsy and seizures, gastrointestinal disorders, feeding and eating challenges, things like pica, where they may ingest things that are non-edible, or rumination, where they have a hard time keeping things down and swallowing it and actually ingesting the food, and obesity as well. So whether or not an individual has autism or not, there is still a huge stigma with mental illness. People are reluctant to seek treatment or seek help because they feel a lack of understanding by their friends and their family. There may be fewer opportunities for them as far as school and work and housing. Health insurance doesn't always tend to be the greatest when it comes to covering mental health diagnoses. And then just the belief that something's wrong with you, that you can't succeed because of this, that kind of label that can put people down instead of lifting them up. Individuals with mental illness are also very likely to be the victim of a crime or bullying or harassment, and less of the perpetrator of the crime. And when we have individuals with intellectual developmental disabilities, sometimes the presentation of the mental illness doesn't always come across the same way. So we have to look at it from another lens to say, what is really going on here and how is their initial diagnosis impacting their mental health as well. All right, so we talked a little bit about autism. Now we're going to talk about how do we work with people with autism. So to understand individuals with disabilities that we care for, we want to remember that all individuals need to be treated for and recognized for what they can do and less of what they can't do. If we come from a strength-based approach, we're more likely to be successful in instead of telling somebody that you can't do this or you shouldn't do that. If we focus on all the positives and encourage them to do more and to learn, we actually are more successful with it. So we want to provide these individuals with understanding. We want to learn what they're going through, and we want to respect them for their uniqueness. So working with individuals, we want to know who we are. We need to have some awareness of who we are and where we fit in our roles as a caretaker, a friend, a family, whatever it might be. We want to make sure that we understand the way that we look at ourselves and how we look at our relationship with others. Understanding this helps us to be more effective in working with others and cultivating a better sense of who we want to be. For this slide, self-identity. Self-identity is composed of relatively permanent self-assessments, things like personality, our attributes, our knowledge, our abilities, occupation, hobbies, things that make us us. Our self-identity is not restricted to right now, but our past selves, who we were and how we've grown to here, and our potential future selves. Who do we want to become? So it's constantly changing, but we take all the things with us and our experiences to better ourselves as to the best of our abilities. So one thing to know about who we are what are the boundaries that we have? Our boundary lines in a personal development sense is more difficult to see than when we think of physical boundaries, right? So our personal development boundaries is our preference and our rules about how we have things in place. Things like what a behavior you'll accept from others, right? Our frustration tolerance with others. Things that we will accept as far as, providing our time, our physical boundaries, our emotional boundaries. And it's really important to know what those boundaries are so that we have the ability to say yes or no to different events and situations. I know my self-identity enough where if someone asks me to do something and I'm not really sure if I can do it, I have the comfort in saying no because it's something outside of my boundaries and my abilities. And it's okay to admit that. I would rather do that than set myself or put myself in a situation where I do fail. So it's really important to know what we will tolerate from others and what we're also willing to engage in. So some of the things that affect us and the people we serve as far as our worldview is how we perceive others around us and just the future kind of as well. So how do we adapt to changes that take place? Things like coping with a diagnosis, whether it's ourselves or our loved one. If you are a parent, challenges in raising a child with a disability, some of the things that you overcome and your frustrations in being able to provide care or assistance and support to those people. Seeing how society treats you and your child or the individual that you're working with. We've come a long way in being understanding and accommodating to individuals with disabilities, but there's still a little bit of a stigma. So doing things like this Autism Training Center is hoping to reduce that stigma so that we don't have such a negative worldview by past experiences and how we're treated. And being very flexible, adjusting to the constant need and change of your loved one's life and yours as well. So how can we help? We always want to practice the golden rule. Treat others the way you want to be treated. Self-explanatory. Whether they have a disability or not, we want to treat others the way we want to be treated and hope that we're treated the same way. We also want to encourage independence. Just because someone has a disability does not mean that they need or want your help. So we always want to ask for permission first if we can assist them, and kind of letting individuals fall if they do, but trying first. Let me see how much you can do, and I'll be there to catch you and help you and give you the support that you need. Okay. Offensive labels. It is so important to speak to individuals with a disability or some sort of diagnosis by using people first language. Using people first language takes the label away and takes this negative stigma that's kind of attached. So on the next slide for people first language, I have some examples of the offensive labels that tend to be imposed onto individuals, like autistic. We don't want to say, oh, that person's autistic. We want to say that's a person with autism. Mm-hmm. If they have a birth defect, it's a person who is disabled since birth. If they are deaf, dumb, hard of hearing, we want to say there's a person who has deafness or hard of hearing. It's always a piece of who they are, not the whole picture of who they are. All right, so that's very helpful with working with others so that we're identifying that this does not define you. It is something that you have, and we're working through it. Communication, very important. When you interact with a person with a disability, talk directly to them. Don't talk to their companions, their aides, or interpreters. And we're coming from a group of people who already are working with individuals with autism or know somebody. So I'm sure you've been to the grocery store or the bank and they're looking at you. We want to try to promote their independence as much as possible and let them speak for themselves. A great, very quick short story where I went to Dunkin' Donuts with an individual I served, and she wanted a coffee colada, but she couldn't say it. And she would say, I want a coconana. And the person looked at me like she was crazy and she didn't understand. And then I came in and said she would like a coffee colada. So she felt so empowered and proud of herself that she ordered it. And I was just there to give some assistance. But that's what we want to do. We want to let them go first and try, and we're there just in case they need us. All right, so on the next couple of slides that we're going to hit is some other ways to approach individuals with different disabilities without being offensive. So I know it's a very tiny slide. There's a lot of words on it, but I'm going to go through each one. So the first one is blind or visually impaired. When you're working with someone who has a visual impairment, you always want to let them know that you're in the room and when you're leaving the room. We want to make sure that they know who's in their surroundings and we're not just having a conversation and then walking away and they have no idea that we left the room. So it's really important that we letting them know that we're in their presence and then we're also leaving. Individuals with cognitive disabilities, we want to use clear, simple sentences. Too much may be overwhelming to them. So we want to give them exactly what they need to hear and exactly what we're asking of them without them getting lost in too much words. We also want to be patient, as it might take them a little bit more time to process what's being asked and to respond. So having that patience is also very important. If someone has a speech impairment, give them as much time as they need to communicate back, especially with a stutter or a stammer. When you end up trying to help and finishing the sentence for them, it actually makes them more anxious and more frustrated and leads to more stutters and stammers. So be patient, let them speak for themselves and let them know it's okay. If someone is deaf or hard of hearing, ask them how they communicate. Do they lip read? Do they use sign language or pictures or write things down? We want to make sure that we're finding how they communicate best so that we can gather information and have a conversation back and forth. All right, so an individual in a wheelchair. When you interact with someone who uses a wheelchair, you want to make sure that you're not leaning on their chair, you're not holding onto it. You want to try to put yourself at eye level, so either by squatting or a seated position, but we don't want to look down on people. One of a quote that we have from an individual who uses a wheelchair said, "I'm not a wheelchair victim. Wheelchair victims are the people I run into at the supermarket." All right. I just thought that was very funny. Okay, behavioral observation. Behavioral observation is so important to working with individuals with autism. We want to make sure that we are not misunderstanding individuals and that we're looking and observing and taking notes so we can make these connections. One of the most common things I hear with people who work with individuals with disabilities is it just happened out of nowhere. That's usually never the case. Something happens. So if we can start observing and taking notes, we can make a bigger picture to figure out what's going on. Lower functioning individuals who may not be able to communicate verbally will show some sort of discomfort, whether it's yelling or vocalizations or the way that their face changes if they look like they have disgust. But we need to make sure that we're looking for these keys and these cues to make sure that that's something we need to evaluate and how we can reduce that anxiety and that discomfort for them. So we're taking research, we're doing the best we can to make a picture. We're utilizing any mental health professionals if available, psychologists, psychiatrists, who are going to give you also opinions on how we can help, whether it's medication or what we can do to change their environment or their situation to reduce those behaviors. Okay, so what are behaviors and why do people have them? Every behavior has a function, whether it is a positive behavior or a negative behavior. There is a purpose for everything that everybody does. And it usually fits one of these categories in meets. Is it a medical reason? Is the individual hitting them in themselves in the head because they have an ear infection? Okay. Is it E, escape, avoid, delay? Are they running away from you because they don't want to go to the doctor, or they don't want to, come down for dinner? Are they trying to avoid doing something by engaging in that behavior? Attention seeking. Do they feel like they're not getting enough attention from you or from someone around them? So they're engaging this attention or engaging in this behavior. So now that they're the focus of the attention, and attention doesn't always have to be positive. It can be negative too. So even if I'm getting yelled at or I'm in trouble, I'm still getting attention. T, tangible, access to places and things. Am I throwing a temper tantrum at the grocery store by laying on the ground, kicking and screaming because I was told I can't have that candy bar? I'm trying to get access to it. And if I make a big enough scene, maybe my mom will give it to me anyway, right? And last but not least, sensory. Is there something bothering them? Is the lights too bright? Are their clothes itchy? Have you ever had a tag in the back of your shirt that's just itching you like crazy? Is that causing them so much distress that they're acting out in some way that's unhealthy for them? All right. So when we do our behavioral observations and we look at the whole picture, what happened before, what happened during and after, we can kind of pinpoint what was the function of that behavior. Every time I go into the store during the holidays, my loved one starts screaming and yelling every time they hear Mariah Carey, All I Want for Christmas. Well, now I know I'm not going to play that song around them because they're telling me and giving me information that's upsetting them and that's bothering them. So when we have that information, we can adapt and reduce some of that behaviors so that they are more successful in their daily lives. Other factors to consider: what is their quality of life? Are they happy? Where does their happiness come from? What is the type of disability? If you're talking about an individual with a wheelchair, do they engage in more challenging behaviors because of their frustrations or their displeasement with their situation? What past experiences? This is very important when we talk about individuals with autism and developmental disabilities. With not understanding situations, did they have a bad encounter at a doctor's office, with the police, with a teacher in school? Are they remembering something that happened to them and they're starting to show the behavior because of what they're thinking about? Their environment, their mental health, and their expectations, whether it's the expectations we're imposing on them that maybe they feel like that they can't accomplish, or the expectations that they have for themselves and they're frustrated. Things like, I want to get a house and get married and get a driver's license, but maybe it's a little bit more unrealistic depending on their situation. So it's important to consider all these factors as well. Behavior modification. When we understand the function of contributing factors of behaviors, we can continue to work or reduce, eliminate that distress and discomfort that's associated. So this slide, the Autism Resources for Families, this was just something I wanted to include just for people to have a little bit more information. If you want to do some more digging, there's great websites, great videos that can show some of these challenging behaviors. TED Talks is amazing on up-to-date information and research. And then I like to throw out some autism positivity. How is it being showcased in a positive manner? So there's TikTok accounts and shows like on Netflix I mentioned before, Facebook groups. And I know I mentioned earlier, it's not on this slide, but Navigating Autism is a great resource for parents, especially of young children, and different resources that are available. I also wanted to do a plug as well for an article I actually wrote in 2020 called Promoting Improved Social Interaction to People with Autism Spectrum Disorders, Re-Imaging Representation in Television and Social Media. It's so important that we have this awareness and this understanding so that we can bring the awareness to others in the community who may not have the information. All right, so we want to make sure that people have the information instead of just being afraid of something that they don't understand. Okay. Here's my referral contact information. If anyone has any questions or concerns after this presentation, my email and my phone number is included. And now I'm going to pass the presentation off to Dr. Arnold Cabasso. And he's going to talk about some of the actual diagnosing of autism and its tools. Thank you very much.
Thank you.
Kristin, it's still yours.
Just enter.
Just keep pressing.
Enter.
Thank you. Okay, Kristin did an excellent talk on what the characteristics of autism are, how we work with people like that. Very sensitive, very excellent. I can see why Kristin won the CP award this year. Congratulations. Okay, I'm going to talk about when people want to go into a program like OPWDD, which funds numerous other things such as residential, service coordination, etc. They need a professional to certify that. And the young lady with the cap had asked about testing for different things. So I'm going to talk specifically about that. Usually babies or children are brought to a developmental pediatrician or a pediatric neurologist because milestones are late or there are behavioral manifestations. And that's when the child is very young. There's something that is seen, and those people are specialists in doing that. But later on, so the clinician, those doctors use specific criteria that are in the diagnostic and statistical manual. It's the book of diagnoses that include other mental disorders like schizophrenia, intellectual disability, bipolar disorder, and the symptoms of autism, which Kristin had gone over, include deficits in social emotional reciprocity, deficits in nonverbal communication, deficits in maintaining relationships, stereotype behaviors, things like rocking, which could also be self-injurious behavior, insistence on sameness, difficulty with making changes, highly restricted interests, as Kristin had gone over, people who know everything about, let's say, trains, which is a big interest with a lot of boys, hyper or hypoactive reactions to stimuli. Yes.
Could you elaborate on insistence and sameness?
Insameness, sure. There was a movie about 25 years ago called Rain Man. Okay, those of us who are not young remember that movie. It featured a high-functioning man with autism who was taken out of an institution by his brother because he wanted money, but he drove him across country, and it was time for jeopardy as they were driving on an interstate, and the brother with autism starts getting very upset and was self-abusing because it was time for jeopardy, even though they were driving on Interstate 80 or whatever it was. The next scene, which was funny, because that's how the movie wanted to portray it, they get out of the car and you can see them banging on a door. They're standing on a porch. These strangers open the door for them so that they can watch Jeopardy. And you see the two of them sitting in these strangers' living room because it's time for Jeopardy, and who cares if we're on a highway. But you see it with young children when it's hard to get them to do something, and then once they're doing it, you can't get them to stop. So it's the insistence on sameness. Okay, in the last few decades, the need for standardization, I went over all those symptoms, but how much of each matters, and we all have our favorites. So insistence on sameness happens to be one of the ones I always look at, but there are others, and I guess most clinicians have one or two that they always look at. We just hired a new psychiatrist in the clinic, and he talked about, well, do they look at fans as they're going around? And that is a common thing, but someone may not have that. So there was the need for standardization, and levels within each area were realized. So different tests were developed. So one of the big ones is the ADOS, the Autism Diagnostic Observation Schedule. This is an up to 4-hour observation by a clinician. Yes, it's a long time, which is why we don't use that. I want to go home eventually. The Autism Diagnosis Interview, which is revised, which is a clinical diagnostic instrument for assessing autism in children and adults. And the one I use in the clinic, the Childhood Autism Rating Scale, or CARS. It's a questionnaire along with an interview. I'll show you so this is the questionnaire that I send out to the parents, and they send it back. They come back with it when I do the actual interview with them. So this,
Excuse me,
sorry.
Is there an option that you go over it with them?
Yes.
Instead of sending the questionnaire?
well, they don't send it to me. They come in with it and I go over it with them. And then there's the second part, which is this, and I'll read some of what it says in there, okay? Okay, so the parents or caregivers are first given a questionnaire. Let me read, it's a good time to read this. No, I would have attached this to the presentation, but there are copyright rules, and I would have been arrested walking out of here if I did this.
Understood.
Yeah. Okay, so number 3 is how does a person move his body? I think I talked about people who rock or look at certain parts of their body, and that could extend all the way to self-injurious behavior. I did a psychological a week ago today and today on somebody using this test. And as I was giving him an IQ test, which is not this, he every once in a while would look at his hand like that. It's a very, very subtle
Mhm.
stereotype behavior. He also rocked, which was more obvious.
Yeah.
Okay, and when you asked me about changes in routine, so I'm not going to go over that again.
Mhm.
Okay, so, and on this form, there's also room for a narrative. And that the mother of this young man, he was 15, wrote down very long information, a lot of information for me, which he didn't even give me during the interview, but she wrote it down. So I was able to really flesh out a report on this guy.
Mhm.
Okay, so then after that is the interview with the clinician, that's me, of course. Within each area, there's a rating scale of 1 to 4. And that's this, I fill this part out and I'll show it to you. Well, I'll read some of it because as I said, I can't show it to you. Within each area, there is a rating scale of 1 to 4, with 1 not involved and 4 highly involved. The clinician reviews each symptom area with the parent along with the individual. And sometimes they're higher functioning and adults. They want to know if they were autistic as a child, and it started then. I usually get good matching between the parent and child.
Mhm.
So the areas on this, there are 15 actually, and again, I know clinicians, or especially doctors, knew the criteria, but this measures each one from 1 to 4, and then they're added up differently. So you can have 1 of a lot of one thing and 4 of a couple of others to make it up. Sometimes I'll say something and the parents will look at me like they don't even know what I'm talking about because they don't rock or they don't have a problem with labels or something like that. So the areas that it goes over are social, emotional understanding. Do they understand other people? Do they understand other people's emotions, or do they have to be floridly explained? And one of the things I sometimes compare it to are, if you watch TV shows in the late afternoon, before the adult shows come on later on, the stuff that's on for 12, 13-year-olds, they overact. And you put it on some of those shows that, like iCarly, I don't know if that's on anymore, shows like that, and they overdo it.
Yes.
So I was a big iCarly fan. Another one is emotional expression and regulation of emotions. Can they control their own emotions, or are they completely flat with their emotions? Next is relating to people. Do they interact? In other words,
Mhm.
body use, which again is like the kid I was talking about. He suddenly would just start rocking once in a while. And as I said, he would look at his hand like this. And you might think he was just like, maybe there was a scar on his hand or something like that. But I saw the way he did that. It was a stereotype behavior.
Mhm.
Object use and play. This is interesting. If you give a kid a toy, let's say a toy car or a truck, they're supposed to use it like a truck. It's not really a truck, but it's it rolls, and you're supposed to drive the truck to a place and put dolls on it or something like that and drive it to the gas station or to school and drop people off. A kid with autism might pick it up and just play with the wheels. It's not being used as a truck at all. It's a thing. Okay. Adaptation to change, restricted interests. That's the story I told you. People who cannot get into something, and then once they're doing it, they can't stop. Another one is visual response, and that's like the way I was saying, looking at certain objects like that. Listening response, people who either sounds bother them a great deal, or you call their name and they don't respond at all. Taste, smell, and touch response. This is, I think Kristin had referred to people who have trouble with labels. Now, I have trouble with labels, so I'm not autistic, but they bother me and I have to cut them out. So, and similar to that is people who have trouble, you see this with babies really, and toddlers, they don't like certain textures, and they will only eat very soft foods. So when I interview somebody, a parent of a child who's not a child anymore, but in their 20s, they'll say they were like that. They would only eat crackers or something like that. And I couldn't get them to eat, hard vegetables or something like that, or they're still like that. I had one guy I did this test on, he would only wear like sweat clothes. Another one only wore shorts, and it was winter, but he could not wear long pants. Another one is fear or anxiety, either too much or too little. Verbal communication, the ability of somebody to communicate. Some people are perfectly good at that. The guy I was telling you about just a minute ago, who was 15 years old, just whispered. It was almost impossible for me to understand what he was saying. It would be 1 or 2 word utterances, but it was very hard to understand him. Nonverbal communication. Every once in a while I go like this, or I make eye contact, I'm looking at you. That's nonverbal communication. Thinking, cognitive skills. There has to be a certain level of intellect, and and what often happens with people on the spectrum, and it relates to spikes in their abilities. So somebody who's really good at mathematical ability, or has a tremendous memory and can't do any math. So when there are spikes in their abilities, that scores higher on that. Okay, this is it. The scores are added up and tallied so that, again, somebody can have a lot of points in one area and almost nothing in something else. This guy who was 15 years old was extremely high. He had almost everything, almost every symptom you could have. But other people just have one area or another, and it's more minimal. So as Kristin said, there are 3 levels of autism, and this test covers that. So numerically, that might add up to minimal to no symptoms of autism spectrum disorder. The middle area is mild to moderate, and the highest is severe symptoms. I'm the psychologist, licensed psychologist for Juanio, and I'm the psychologist in the Cornerstone Clinic. So if people want OPW, DD eligibility, I'm the one that they see. I do IQ testing, autism testing, and a bunch of other things. Okay, thank you.